to the ciliated organisms, that's the next family. So when I talk about free living amoeba, we have Naegleria fowleri, Acanthamoeba and Balamutia, which are the most important ones. So let's start. I'm going to actually first show you the life cycle of these two, Naegleria and Acanthamoeba ka. This is the life cycle of Naegleria fowleri that we have. Like every other organism, this also has a cyst and this also has a trophozoite. But if you look carefully, I've written cyst over here, but in trophozoite I've not written trophozoite, I have written flagelliform, because I want to tell you that cyst to cyst ki tarah dikhta hai, like a round cyst everywhere it has. But the trophozoite that we have, that is known as the amoeboflagella. Trophozoite is also known as amoeboflagella, which basically means that when it wants, it will have a flagella, right? It is the, many people don't know that this is the only free living amoeba that can be flagellated at times. So when it wants, it will have a flagella, and when it will, see, you can see the flagella coming out from here. When it wants, it will have a flagella, and when it doesn't want, it will start going into an amoeboid form. So iska matlab mood swings hota hai. Sometimes it is an amoeboid form and sometimes it's going to be a flagellate form. So that is why we call it the amoeboflagella. Everyone's understood? Naegleria fowleri kuch foul play kar raha hai. What foul play is it doing? It is becoming little smart, that despite being a free living amoeba, Naegleria fowleri is trying to show me a foul play. That is, it's trying to show me F for fowleri, F for flagella can be there. Now moving on to the next, how does it come to us? So I can see over here that only this fowleri is actually playing a foul play. Only the flagellate form, the amoeboflagella is coming to me. The cyst is not coming to me. So if I ask you, what is the infective form over here? The infective form is just what is playing the foul play. So now you understand why I was saying foul play, because that is foul, sometimes flagellate, sometimes not. That is only fouls. It is coming into my body. So that is going to be the trophozoite form, or in other words, I will call it the amoeboflagellae form. Fine. How does it come into the body? Free living. It was free living in the environment. So this is going to come via, you can see the person is inside water if you look carefully over here. This is going to come via swimming. Basically, they will say that either the person has gone to his village or he's gone to a pond or some recreational swimming. So some swimming ka history has to be there, pond, river, somewhere he'll be swimming. And obviously if he's swimming, then via the nose the water can go in. Na? So now what will happen, that blue color water that I want to show you over here is going to go via the nose and reach the brain. How will it reach the brain? From the nose, cribriform plate. From the cribriform plate, it's going to reach the brain. So it's going to reach the brain and it's going to cause PAM. What is PAM? That is what I can tell you. The first thing about Naegleria fowleri is it causes a disease called primary amoebic meningoencephalitis. That is what I'm calling as PAM. Primary, because it's primary, coming first time. Amoebic, it's a free living amoeba. Meningoencephalitis, via the cribriform plate, it goes into the brain. So primary amoebic meningoencephalitis is what Naegleria fowleri is causing. Now moving on. There's another one which I call as acanthamoeba. Now what is acanthamoeba? If I look carefully over here, look at the word acantho. Acantho word ka kya matlab hota hai? Acantho always means spikes. So if you look at the trophozoite of this particular organism, can you see the trophozoite is showing you spikes? That is how I will identify this life cycle. Trophozoite shows you spikes, and then it also has a cyst form. What is coming to the humans? I can see the cyst is also coming to the humans. I can see the trophozoite is also coming to the humans. So I have learned acanthamoeba mein all the things are coming to the humans. If someone asks you what is the infective form, you will say everything. Trophozoite also, cyst also, all is infective. How is it coming? I can see it is coming via the inhalation route also. It is coming via the ingestion route also. I can see it is coming via the eyes and the skin also. So now what is the mode? That is also all. So acanthamoeba में सब कुछ is all. The mode of route of getting the infection, it could be anything, all. It could be inhalation, it could be ingestion, it could be cutaneous. And if I ask you what are the forms coming in, again all. Trophozoite is also coming, cyst is also coming. What is it going to cause? Now that is going to cause game. What is game? That is granulomatous amoebic, either you call it encephalitis or meningoencephalitis, whatever you want to keep it. So granulomatous amoebic meningoencephalitis is gonna occur by acanthamoeba, the spiky one. So spikes pehen ke we play na, we run marathons, we play cricket, spikes pehen ke. So spiky wala organism is very important for me to play a game. Acanthamoeba, the one that is going to have spikes, that is the one I will wear the spikes and I will play the game, that is granulomatous amoebic amoebic meningoencephalitis. And in Naegleria fowleri, please remember, fowl kya hai? Because number one fowl, it has a flagella. That is number one fowl that it has done. It has a flagella which no one else had. And there's another fowl that it was doing was. So now we've come down to two things. Naegleria fowleri causes PAM and acanthamoeba causes game. So now let's understand the risk factors. Did I tell you Naegleria fowleri was by swimming? There was some pond swimming history. You know how acanthamoeba occurs? There will be some history of immunodeficiency. They will either give you an HIV positive patient, organ transplantation patient, some immunodeficient situation will be mentioned. Then tell me, in Naegleria fowleri, what was the infective form? Only and only the flagella wala form. Only the fowl. Remember I said fowl means it has a flagella, and that fowl is that the flagella wala form is infective. That is what we are doing again and again. Number one fowl is that it has a flagella, and that flagella wala form is creating the fowl. That is the one that is infective. So that was the trophozoite. The trophozoite had a flagella. That was creating a fowl, and that was infective. Okay? Trophozoite has a flagella creating a fowl, and that is infective. Whereas acanthamoeba was everything. The trophozoite is also infective. The cyst is also infective. Now talking about the clinical course. Dhyan se suno. When I say granulomatous, go back to pathology. Granuloma is what inflammation? Chronic inflammation. Na? So what do you think is going to be the clinical course of this condition? It's going to be chronic. This means Naegleria fowleri is going to be acute, and that means I will get a history of fatality within very few days. You go back to your previous year question, you will see the girl had gone to her village for swimming. Within 5 days, she succumbed to the illness and died. But jaldi is going to happen. That is the foul play that is happening over here. Na? Jaldi it is going to happen. Whereas granuloma means late, chronic inflammation. How is it spreading? Again, very simple. Remember, Naegleria fowleri was swimming, going through the cribriform plate and into the brain. So this was a neural kind of a spread. Whereas acanthamoeba could occur via inhalation, it could occur via ingestion. So it's going to enter into the blood. This means it's going to have a blood route. So I don't think you have to mug up as such this table. Little bit of logic you put and you are sorted. That for Naegleria fowleri, I have the fowl wala, that is the trophozoite which has a flagella, that is the fowl, and that is what is going to be the infective form. How does it enter? It enters via the nose. So matlab via the neural route. From swimming it enters into the nose. Via the neural route, cribriform plate, it will go to the brain, and over here it is going to cause primary amoebic meningoencephalitis. Whereas talking about the acanthamoeba has spikes. All the routes are possible. Inhalation, ingestion, cutaneous. All the things are going to be infective, trophozoite as well as cyst. So when it's going everywhere in the body, it's going to travel via the blood. What does it cause? It causes granulomatous amoebic encephalitis. Granuloma is a chronic condition. Let's move forward and let's look at the rest of the table. How would you do the diagnosis? Of course, you're going to look at the CSF in both the situation. है ना? CSF तो देखना ही पड़ेगा. So CSF में, of course, we will see it's very similar to a bacterial meningitis. Primary amoebic meningoencephalitis is very similar to bacterial meningitis because CSF will show you lots of polymorphs, neutrophils. And of course, trophozoite foul play कौन कर रहा था everywhere? Trophozoite is going to be doing the foul play. Acanthamoeba, I told you that this is going to go in the blood and to all the parts of the body, and all the forms are going to be seen everywhere. सब कुछ all होता है. You will see trophozoite also, you will see cyst also. The culture of both of them is the same. Both of them are cultured on NNA. What is NNA? Firstly, you need to know the full form. NNA stands for non-nutrient agar. NNA stands for non-nutrient agar, and please note that this is actually a lawn culture. You guys have read that in culture media. This is a lawn culture in which what is laid down? This is going to be E. coli. E. coli matlab entamoeba coli. ठीक है, not Escherichia coli. So NNA is done with E. coli. That is the culture for both. But the gold standard always, genetics is always going to be the gold standard. Na? So what is NAAT? This much also you know by now. You have probably studied it in a lot of places. What is NAAT? Nucleic acid amplification testing. Nucleic acid amplification testing is what is being done. Matlab PCR ka form na. So PCR is always going to be the gold standard. Finally, coming to the treatment. For the treatment of Naegleria fowleri, we have amphotericin B that is given. That is one thing. But for again acanthamoeba, it is because patient is immunocompromised, immunodeficient patient. So in most of the cases, we can not understand only that what exactly needs to be given. So a combination of drugs, again all, sab kuch all drugs ka combination you will have to put up. You might have to combine pentamidine with azoles, with flucytosine, with sulfonamide. So you have to multiply the drugs and you have to give a combination combination out there. So everything is all the forms, all the roots and all the drugs have to be combined and given up over here. So have a look at finally, ye jab itna all kar rahe hain, have a look at the pictures of acanthamoeba. I told you the first word, acantho word, is going to have spikes. So you will have to pick up something that has spikes, and I can see over here that there are definitely these spikes that are coming up. So this must be the trophozoid form. This must be the trophozoid form, which is going to have the presence of spikes. Then how does the cyst form look like? If I look very carefully, look at the wall, the outer wall especially. Can you see the outer wall is wrinkly like this? Inner may be wrinkled, may be smooth, but outer wall is wrinkly. And that is how you identify the cyst of acanthamoeba. There is a wrinkled wall, especially I'm mentioning the outer wall is wrinkled, very, very important. So I hope everyone has understood this about acanthamoeba, the spikiness and the wrinkled wall. So these two are done. There's a very close organism known as Mandrillaris, that is B. mandrillaris, Balamutia mandrillaris, and if you look at it, you will say that, ma'am, this is very, very similar to acanthamoeba. It's very, very similar to acanthamoeba. So let us pick up the differences that we have, okay? And I will correlate this with ophthal also, so hang out. Now, what was acanthamoeba causing? Granulomatous amoebic encephalitis. Balamutia also causes the same. Okay, what were the forms of acanthamoeba that you saw? You saw trophozoites and cysts. So Balamutia also shows you the same. So yahan tak to same chal raha hai, but now there must be a difference in the shape, na? Can you see the trophozoite is somewhat looking like a fish? Yes, can you vaguely, imaginary way mein, can you make a fish out of it? Yes, so the trophozoite, I've shown you, the trophozoite is basically fish shaped. The trophozoite is going to be fish shaped, and the cyst is going to be a little more smooth. The cyst is not wrinkled. The cyst is going to be a little more smooth. So ye to chalo ma'am, finally I found one difference, that patient might have, in both the conditions, patient has granulomatous amoebic meningoencephalitis, but when I look at the cyst and the trophozoite, I'll be able to differentiate. One more thing. Do you remember acanthamoeba was only occurring in immunocompromised states? Only in immunocompromised states, whereas Balamutia can occur in both the situations, in a normal immunocompetent person also and in an immunocompromised person also. Clear? So microscopically different dikhega, clinically patient may be different dikhega. I've done one clinical difference and I've done one microscopy difference. One ophthal difference. Which of them can infect contact lenses and cause keratitis? Which one of them can do that? I hope you guys have read this. Which of them can infect the eyes? Acanthamoeba. Very, very important. So this is an ophthal correlation that I'm doing. In contact lens users, keratitis can occur, and that will occur with acanthamoeba. That will not occur with Balamutia. So I can write that over here for you guys if you want. There is going to be no amoebic keratitis that I'm going to see over here. Is that okay with everyone? Sorted? Can I, quickly solve a few questions related to it so that we get more clarity on this? Let's get going. So let's pick up two questions out here. Firstly, you have a patient with contact lens who developed corneal ulcers and symptoms of conjunctivitis. Saline mount preparation of the corneal scrapings showed a double wall cyst with an irregular or a wrinkled outer wall and a smooth inner wall. Whose cyst is being defined? So first and foremost, there was a contact lens usage. Okay, in a contact lens usage, I am seeing a patient having keratitis. Acanthamoeba comes to my mind. And as soon as I say that and I see the wrinkled wall, of course I know I am dealing definitely with a case of acanthamoeba keratitis. Anyway, you look at the others, Naegleria, Entamoeba, Giardia, they are not corneal ulcer related things. Let's pick up one more previous year question for all of us. Here you have a 15-year-old girl, this is a PYQ, who has in a village, she has returned from a vacation visiting her friend in another village. She complained, so basically when they wanted to give you a village history, how do people in village usually take a bath? In some pond or some water body. So they said that she's complained of severe headache and fever, and clinically she has been diagnosed as a case of pyogenic meningitis and admitted in the hospital. Because did I tell you pyogenic? Maybe CSF was also showing you lots and lots of neutrophils. They said this is a case of pyogenic meningitis, but look at what has happened. Within 5 days, very, very quickly, some foul play has happened and she has died very, very quickly. What is the organism that you'll consider? So firstly, we have a classical history of swimming, and as I said, within 5 days she's died, to kuch to foul play hua hai, and this means this is a case of Naegleria fowleri. So that's the answer that you have over here. I hope everyone is sorted with this information. We are done with this. Free living amoeba, done. So the next organism, which is a short family that I want to wrap up now, is the ciliated organism. In fact, this is the only ciliated parasite that I would be talking about. So please listen out very carefully, and it's a beautiful story that I have to share with all of you. When I'm talking about Belantidium coli, the way you will write it, you will write B. coli, which means coli will remind you that it is celi. Coli will remind you it is celi. It is the only ciliated parasite that you have in humans. Then the B of Belantidium will remind you of a lot of bees. So if I ask you what is the size, you will say it's big. It is the largest protozoa that you have in the human intestine. It is very, very big. Which intestine is affected? Big intestine. The large intestine is affected. So simple. The B is telling me it's big in size. B is telling me it's very, very big in terms of the intestine, large intestine affected. And next you will see that what are the two forms? Everywhere, guys, the two forms shall always and always be the trophozoite form as well as the cyst form, right? So please remember, both the trophozoite and the cyst are going to be binucleated. Both the trophozoite and the cyst are binucleated. So till now, if you remember, for example, if I make you quickly do something, Entamoeba histolytica, how many nuclei in the trophozoite? 1. How many in the cyst? 1 to 4. Entamoeba coli, how many nuclei in the trophozoite? 1. How many in the cyst? 1 to 8. But when I'm saying Belantidium coli, the trophozoite and the cyst are the same. This also has 2 nuclei. This also has 2 nuclei. Let me show you pictures. Have a look at this, guys. You will see one very big nucleus over here and one very tiny dot over here. A very big nucleus over here and a very tiny dot over here. So when I'm talking about the situation that it is binucleated, when I'm saying it is binucleated, I am trying to say that there is a big nucleus, big ya fir macronucleus, and that macronucleus, did you notice the shape of that big nucleus? It was bean shape. This macronucleus over here or the big nucleus over here was basically B for B, that is bean shape. Whereas there is a small little nucleus over here which I call as the micronucleus, and that is just like a tiny dot, which you can see again. There is a micronucleus which is just looking like a dot. So simple, another BB coming up your way, that if you have a big nucleus, that is going to be B for bean shape, that is going to be B for bean shape. You can see that everywhere. Also, if you look carefully, two chota lines you will see over here, that is just indicating that this is a ciliated organism that we have. Now, are these cilia only for show off, or with the help of these cilia or kind of pseudoflagella, can it sometimes show a motility? Yes, please remember, it can show a motility which is known as the rotatory motility can be shown. Rotatory or active motility can be seen in these patients. Other than humans, can they have any reservoir? Yes, they can have pigs as a reservoir. Extra information that I'm telling you. And for the treatment, what are you going to give? You're going to give doxycycline. So these are some extra points about Belantidium coli. It's very unlikely to be asked. But what are the main points that you will get? The mnemonic, of course. Coli reminds you of celi. It is ciliated. B for it is big in size. B for it is big intestine. And B for it is going to be binucleated, whether trophozoite or the cyst. But which is infective out of these? Infective हमेशा cyst होता है. Most of the cases the infective form is the cyst only. Before we end it, quickly solve this question. Previous year question, all are true about Belantidium coli except, is it a protozoa? Yes. Is cyst the infective stage? Of course. Is it the largest protozoan or the parasite inhabiting the large intestine of the man? सब कुछ big? Yes. Is it invading the liver? Did I talk about anything to do with the liver? No, I was only talking about big intestine, big parasite, big intestine. So this is